Top Med Talk.
Monty Mython here. As we prepare to move into the next phase of the COVID crisis, we're going to be widening our focus here on Top Med Talk. We will continue to deliver COVID-specific programs, but we all have a huge additional responsibility as we try to reboot normal services. So although this piece is not directly related to COVID-19, we believe it's information that is crucial to the bigger task of rebuilding the healthcare system as we learn to adapt and live with this new virus. Thank you to our sponsors and to you, our listeners, for helping us to share this important information.
Nick Geriatrician here. Welcome to Top Med Talk. This piece is taken from the 8th Australian and New Zealand Symposium of Perioperative Medicine Special Interest Group. Updates in Perioperative Medicine 360, which took place between November the 7th and the 9th of 2019. Hope you enjoy this talk, and if you do, don't forget to check out topmedtalk.com and make sure you subscribe to us on social media as well. More details about that to follow. Before that, let's enjoy this talk.
Professor Jackie Close, who's a geriatrician from Sydney.
Thank you, David, and thank you to the organisers for inviting me, and particularly for making me the last speaker in the last session of the last day. Okay, so I've been tasked with ward-based post-operative care. What matters? Fasten your seatbelts because we've got quite a lot to get through in a relatively short period of time. I'm going to cover Be Prepared, a little bit on autonomic dysregulation, getting the basics right, which is something I feel passionately about, nutrition, falls prevention, which is rarely brought up here, and reasonably so, delirium prevention and management. So when you're talking about post-operative care in the elective setting, I would argue that the die is often cast in the pre-operative setting, and what you do in the pre-operative setting makes a big difference to what happens post-operatively. So when we're talking about, for me as a geriatrician, an older person coming in for elective surgery in the pre-op setting, we're talking about altering physiology and psychology, such as exercise and nutritional interventions. We're also talking about identifying risk, so risk that we might not be able to alter in advance of surgery, but information about that risk is important. Cognition is the obvious thing to think about there. And then for a lot of older people, we should be care coordinating before we operate. And on the whole, when you put all of those three together, that's comprehensive assessment. So all scouts and girl guides, be prepared. So here's an example of someone where it was important to be prepared. So this was an orthopaedic surgeon, a shoulder surgeon, who asked me to see somebody in advance of surgery, not to do with whether we could get them through an anaesthetic. That's not my area of expertise. It was, are we going to make a difference to this individual's life, and what are we going to run into in the post-operative period? So it was somebody 75 years of age, severe OA of his right shoulder, pain and also increasing restriction, including difficulties with personal care. Background of cognitive impairment, no formal diagnosis of dementia, death, that's not uncommon. Previous history of delirium in the context of a hernia repair, lives with his wife, he's got 18 internal stairs, he's an outdoor mobiliser, still uses public transport, goes out with his wife fairly regularly. So there's an example of what a care plan for that individual would look like, but from a geriatrician's perspective. Now, I'm not waiting for Ianthe to produce data on orthopaedic patients and that deep breathing exercises is good for them. If deep breathing exercise is good for people having abdominal surgery, I think it's probably good for everybody. He's going to have an arm that's immobilised for a number of weeks. We might as well get him practising doing what he needs to be able to do after the surgery in advance of the surgery. So practising doing those 18 stairs using his left arm only. He's likely to struggle with a PCA if he's given a PCA after surgery. Stop his telmisartan on the day of surgery. Document his cognitive status. We use the 4AT. Document his ceilings of care. Who's his substitute decision maker? It was his wife in this particular thing. Discharge options. How are we going to manage his personal care with an arm immobilised for 6 weeks? Identify what services occur. Perioperatively, no reason for a geriatrician to be anywhere near the operating theatre, but ideally we'd like somebody cognitively impaired first on the list. I realise we compete with the diabetics. His wife ideally should accompany him to the operating theatre if possible. A pocket talker should go down with him so that people can actually communicate with him effectively. The phone number of his wife is in the notes so that when he's in recovery, if they run into problems with him becoming agitated, they can call his wife to actually sit with him. And often we'll send down an iPod shuffle with some music and headphones to entertain him. Post-operatively, we've already planned. He'll go to a high observation area. We'll use the pocket talker to communicate with him. Pain relief, of course, is critical. Regular delirium assessments, up and mobilising as soon as possible. We know in advance of surgery he will need assistance with feeding. He's right-handed, his right arm is out of action for at least 6 weeks. The table needs to be put on his left side. I know that sounds so basic, but a number of times you see things like that not happening. He's also going to have problems probably using a urine bottle as well. Working with his wife in terms of doing range of motion exercises, and he went home with packs with his wife also helping for discharge. But that's the sort of planning we like to do. However, in the emergency setting, we don't have the option of being able to do that. So let's think through what we're talking about in terms of ward-based post-operative care. So Cliff has come across as a very nice guy. Can I just remind you what he does for a living? He electively assaults the human body on a regular basis. And we're left to deal with the aftermath. So we need to consider surgery as a multi-system physiological dysregulation. That is what we see in the post-operative period. That's what we have to be ready to deal with. So in terms of what matters, there's a hell of a lot that matters. There's some examples up there of what matters. So there's no point in just doing one part of it. So yes, it's great to have a pain team, but there's lots of other aspects of care that make a difference in the post-operative period, and they're all important. So let me give you an example. If somebody's got a hypoactive delirium, and of course any of the other issues that I'm highlighting can trigger the hypoactive delirium, but if they have a hypoactive delirium, we will struggle with oral intake. We'll struggle with nutrition. We will immobilise people who are delirious. They'll have problems with altered sleep-wake cycle. We'll have problems with hypoxemia, basal atelectasis, and we'll have problems with accurately detecting and managing pain. As a result of all of those issues, we'll get functional decline, malnutrition, incontinence, infection, problems with wound healing, increased risk of DVTs, PEs, constipation, and urinary retention. That's the reality. Everything makes a difference. It's not just one aspect of post-operative care. We need to be thinking about all these domains, and in each person, the priority will be a little bit different. So I've got some clinical examples, really just of patients I've seen in the last week or so. This is somebody who came in May of this year, so a 94-year-old, free-range individual, managing pretty well at home, had a valgus impacted intracapsular fracture, for which he had a 2-hole DHS and an anti-rotation screw. All went well, came back, however, to the orthopaedic clinic in early October, and it looks like the anti-rotation screw had gone through the femoral head. There was a plan just to take out the anti-rotation screw in the hope that that was the problem with the pain. But the reality is she was developing avascular necrosis, which is shown in the November X-ray. Of course, it doesn't really matter what the X-ray shows. What did matter is that that woman who went home in May, having had her procedure, walking, was now essentially in a wheelchair. So she ended up having a total hip replacement. She had a total hip replacement on the 5th of November, cemented stem. Lots of trauma associated with that, so the lag screw had to come out, the plate had to come out, her femoral neck had to be sawed off, she had to have her femoral canal reamed, then she has the prosthesis put down and some cement. There is a huge amount of stress associated with that. And she ran into problems during the surgery in terms of her blood pressure. She was in recovery with problems with her blood pressure, and then was back on the ward. Now, she wasn't back on the ward within about 2 hours of her surgery. I think I would argue that perhaps she shouldn't have been back on the ward as often as she did, or as often as she did appear back. And not only was she back, but she continued to be hypotensive, and of course that triggers multiple MET calls or PACE calls. I know we all call them different things. And you get the junior member of staff, and of course their response to hypotension is to tip fluids in. And that's exactly what happened to her. And it wasn't until about 8 o'clock at night that ICU were contacted, and they actually took her to ICU overnight. And they did masterly inaction. And masterly inaction is fantastic. You have to be senior to do nothing. They didn't give her inotropes. They didn't give her more fluids. They simply monitored her. And she was back on the ward within 16 hours. But we do run into problems with blood pressure in the post-operative period, and it is not all about hypovolemia. So orthostatic intolerance is extremely common and very definitely gets in our way of getting people up to mobilise early. So it's characterised by dizziness, nausea, blurred vision, and sometimes people, of course, will pass out. We see it in up to 50% of surgical patients, and it very definitely delays mobilization. It's thought to relate to an attenuated postural vasopressor response and autonomic dysregulation, so they're not able to mount a tachycardia, which you would expect if you drop your blood pressure. So there's multiple factors that contribute to orthostatic intolerance in the post-operative period, not just hypovolemia. It's more common in females. Some question as to whether it is more common with age. People who are on multiple antihypertensives often run into problems in the post-operative period, and some thought that it's related to spinal anaesthesia as well. So how do we deal with it? Well, there's been a couple of trials that have looked at different approaches. So this is a study looking at males undergoing radical prostatectomy and trying goal-directed fluid therapy. Do not worry about trying to read the graphs because it didn't work. So they were able to demonstrate the orthostatic intolerance, but the goal-directed therapy didn't work. Another study a few years ago looked at midodrine. So midodrine's an alpha agonist, which we use, often I will use in Falls Connect for people who run into problems with orthostatic hypotension in the Parkinson's disease. So for this particular group of individuals, so these were people undergoing elective arthroplasty of the hip. And what they tried to do was promote early mobilization and give 5 milligrams of midodrine 1 hour before they mobilized people at 6 hours and 24 hours. And the bottom line is, again, this didn't work, although if you look at all the outcome measures, they're all going in the right direction with the midodrine group, but not enough there to change your practice. Again, somebody I've had very recently, an 81-year-old female from home, tripped while shopping, Parkinson's disease on Madapar, known to have orthostatic hypotension. She's previously had fludrocortisone, didn't like the fludrocortisone because it caused ankle edema, which is common, and cognitive decline not previously diagnosed. So she was another valgus impacted, so it's a different hip fracture, but valgus impacted. She had cannulated screws, this time on the 17th of October. Don't know what happened on the 18th. It doesn't look like anybody got her out of bed. But on the 19th of October, she had her first syncopal event. And at that stage, a blood pressure of 70 over 55 and a heart rate of 75. So not much in the way of a chronotropic response to a really quite marked drop in her blood pressure. So she literally was sitting in the chair and passed out. And there's an example of her blood pressure in the post-operative phase, which very definitely impacted on our ability to get her up and mobilize her. Now, we started midodrine. We started midodrine at a dose of 2.5 milligrams BD and slowly titrated that up. So there's a more recent profile for her blood pressure up until about the 6th of November. She's on midodrine 10 milligrams twice a day, given at 8 o'clock and 2 o'clock. You need to be really careful giving midodrine later in the day because of the problems with supine hypertension. But her drops in blood pressure have largely been attenuated, and she's in rehab now making progress. So just an example that we can do things with orthostatic intolerance in the post-operative period. Getting the basics right. No randomized controlled trials for bringing in glasses, hearing aids, pressure care, but they're all equally important. Bowel and bladder care, nutrition, brain care. Now, most of you in the room are anaesthetists, and you have a whole range of toys that you get to play with in the operating theatres. As geriatricians, our toys are very different. So we have the pocket talker, which we communicate to patients with. we have the Bristol stool chart. So geriatricians are obsessed with bowels. We've got the 4AT. A bladder scanner is as near to equipment as we really get. And more importantly, we've got the delete button and the keyboard for all those dreadful drugs that get prescribed. Removal of catheter. What's your problem? So we've known for years that it's actually important to get catheters out in a timely manner. But not only is it important to get catheters out in a timely manner, we should also remember from a physiological perspective that the way we wee isn't lying in bed. And actually, not only should we take the catheter out, but for men, we should encourage them to stand and wee into a bottle or take them to the toilet if that's what they want. And for women, we should be encouraging them to sit on a toilet and wee, because that's what we do from a physiological perspective. So it isn't just early removal of a catheter, it is restoring normal physiological processes. And there's evidence that, and there's a heap of evidence, I'm just giving you one example. This happens to be in people having colorectal surgery and looking at acute urinary retention and the incidence and how the benefits of early catheter removal. And in fact, early catheter removal led to fewer urinary tract infections and shorter length of stay in hospital. This particular trial used 1 milligram of prazosin, so the alpha blocker 6 hours before removal of catheter. I'm not saying you should all do that tomorrow, but you should all remove catheters early. This is really unhelpful. This is from the Clinical Excellence Commission, and it suggests that remove the catheter providing the patient's bowels are moving. Now, I don't know where that evidence comes from. So occasionally we see people who are constipated and they haven't opened the bowels for 7 days, 10 days. Yes, they may go into urinary retention, but somebody who comes into hospital and haven't opened the bowels for a couple of days, you do not need to wait for their bowels to work to put a catheter in. Post-operative fever, very common. So this is somebody, again, came in, female, had a total hip replacement last Friday. That's that fever. Her white cell count is up, so she was a hip fracture. Her white cell count was up at admission, which is extremely common. We don't bat an eyelid at that. White cell count dropped after surgery, but that was the fever that we saw in the post-operative period. Again, for this, I'd argue this was masterly in action again. It's not that we didn't do anything, it's we actually watched very carefully, we cultured, but this is almost certainly a reflection of an inflammatory response from a fairly major surgical procedure. Now, we know that people that mount these inflammatory responses will do worse, but there was no antibiotics here. We watched and waited, and it settled. Feeding. I hope that I don't need to tell anybody that it's important to feed people in hospital. In the UK, apparently, if you give people an extra meal a day, you halve the mortality rate. I would interpret that carefully. But there is evidence from the Cochrane review, maybe some reduction in mortality, not compelling data from that perspective, but there is data to suggest that if we feed people, we will reduce complications. This is data from the colorectal group of patients. Again, early feeding makes a difference. This was a study that came out last year, a bit disappointing. So this was enhanced nutrition after hip fracture, 10 assessments by a dietitian, and those lovely nutritional supplements provided on a regular basis. And the reality is, despite that particular intervention, they were looking at length of stay as their primary outcome. The intervention actually didn't work, which is unfortunate. But this is probably the most important component of this intervention, and it's actually that they excluded people who were cognitively impaired. And I would argue that it is the people who are cognitively impaired that are most likely to be malnourished when they get admitted to hospital, and they are certainly at greatest risk of becoming malnourished in hospital. And when we think of the way we provide food in the hospital setting, I don't know what it's like at your hospital, our trays are white, the plates are white. Everything is cellophane packaged, and there is no way that you can get off that cellophane if you are in any way visually or manually from a manual perspective, struggling to move them. Early mobilization. I don't think anybody in this audience would argue that early mobilization isn't what we should be aiming for. Lots of potential benefits from it. Well, let's see how we do from a hip fracture perspective. So this is the percentage of people who get the opportunity to get up the day after surgery. So I cannot for the life of me read off this. I'm pretty certain, Sunshine Coast University, Westmead, Townsville, Fiona Stanley, high performers. Down the bottom, Sutherland, Q2, Box Hill, Dandenong, Launceston, General. Big variation in how many people are getting the opportunity to get up after surgery. Preventing falls in hospital. Well, there is evidence. There's actually 24 trials. This is Cochrane from last year. 24 trials, nearly 100,000 participants. So you'd expect we'll have fairly robust data to tell us how to prevent falls. Well, actually, it's not that robust. The orthogeriatric model of care seems to make a difference, and in the subacute setting, there is some evidence for exercise, but those benefits don't start to become apparent until 45 days into the admission. Most of us do not have length of stay of 45 days in subacute. Couple of studies. This is probably one of the better studies around. Very nice step wedge cluster randomized controlled trial looking at the benefits of educating a patient as well as then feeding back to staff as to how to best prevent falls. And it did work. The reality is it did work. The problem is it didn't work in people who were cognitively impaired, and they're the ones in terms of falls and fatalities in our hospital wards run into the most problems. So life beyond the randomised controlled trial. So Ross kind of started that theme at the beginning of the meeting, and I would agree there are some things that don't lend themselves terribly well to randomised controlled trials. And when you're seriously thinking about trying to change attitudes and cultures in an organisation, they don't lend themselves to neat little randomised controlled trials. So this is our data for Prince of Wales. The dark line shows where we were in 2006. So that's 13 years ago. We've been trying to reduce falls, and we have successfully reduced falls over time, and hopefully will continue to do so. But it's not because we did a project. We actually use data on a continuous basis, ownership and accountability for staff, lots of incremental changes rather than a project. There's an example of some of the stuff we've done. Hypnotic reduction. Nothing good about sleeping tablets. We've known that for decades. That's what's happened to our use of sedative hypnotics. If anybody's still awake, you will spot that the graph ends in 2014. So I thought, just in case anybody, Dave Story would probably pick that up. So in case he picked that up, I did check last week how we were doing in 2019, because at some stage you have to stop doing some things. You have to assume that it's gone into practice. So actually we're still pretty good. Last little bit, and I'm over time by 30 seconds at the moment. Delirium. So you've already had Gideon and Alison talk about delirium. There is nothing good about getting delirium in hospital. Not only does it affect your stay in hospital and greatly increase your risk of complications, but actually your longer-term cognitive trajectory is also worse if you develop delirium in hospital. So that's data from the SAGES trial. There's some data out, again, fairly recently showing that the longer your surgical procedure, the greater your risk of developing post-operative delirium. So do you want the most junior member of the team operating on the most frail individuals if that's what happens? So think twice about who operates. Evidence out there that tells us that we can prevent delirium, and none of it is drug-related. It's simple measures on the wards: orientation, communication, feeding people and getting them up and walking. Comprehensive geriatric assessment has benefits in terms of preventing post-operative delirium. We've got evidence from the Cochrane reviews, and in the Cochrane reviews it's the multi-component interventions that seem to work. So in conclusion, be prepared. So I think the die is already cast for a number of people coming in for elective surgery. Remember that surgery is a multi-system physiological assault causing dysregulation. Enhanced care after surgery needs to be multi-dimensional. The simple things really do matter. Not all answers to the questions that are important will come in the form of a randomised controlled trial, and brain care has an impact way beyond the acute surgical episode. Thank you.
Top Med Talk.
It's Desiree Chappell here. Just a quick reminder, subscribe to Top Med Talk. We're a daily source of news and conversation focused on perioperative care. We bring you all the latest talk from all the major conferences in the perioperative space. We can also be found on Twitter, Facebook, LinkedIn, Instagram, and we now have a free mailing list with special offers and additional goodies for subscribers. Go check us out at topmedtalk.com. That's www.topmedtalk.com.